Hello guys. I hope everyone is doing okay. So guys, someone yesterday, one of the students here in Walter Sisulu University, he's a final year, so he asked me to do PEADS cardiology. PEADS cardiology, guys. Anyway, before I do this, I just want to bring something to your attention. At this level, we are not really trained to be specialists, but we are trained to be GPs. I know that sucks, but that's the reality. We are trained to be GPs, and as a result, our job is really to have an idea of things, so that we can be able to pick up stuff and do what we can and refer those that needs a specialist care. So and also as an intern, I've rotated in PEDS already, but I haven't seen a lot of cardiac patients. I saw quite a few when I was a student in my 4th, 5th and 6th year. So having said that, let's jump into it. Okay, so when we talk about cardiac disorders, we need to, in anything, we need to be able to fit things, because medicine is like a build up. You are building up as you go. It's like when you study upper GI bleeding in adults, when you go to PEDS and read about upper GI bleeding, you should still have the same kind of an approach that you had in adults, same kind of a broad understanding, so that you can be able to now say, okay, I've read upper GI in adults, so where do I fit now my pediatric patient who's got upper GI bleeding? Because if you study them separately, not understanding, it's going to be difficult to sort of like be able to put things where they are supposed to be. And if you don't have a broad overview of things, you won't know where you are and where you're supposed to be. That's what I'm trying to say. So cardiac disorders, firstly, we need to know that there is congenital, and then there is acquired. So acquired is, okay, congenital is someone who was born with a heart condition, whatever heart condition it is, but they were born with it. And then now, when you talk of acquired can be, and also you need to classify your acquired nicely so that you can understand where you are. Don't be overwhelmed with cardiology. Don't look at cardiology as cardiology. Say, okay, I've got a cardiac patient, but does this patient has valvular heart disease? Valvular? Or are they having pericardial? Or are they having myocardial disease? Or are they having coronary, like ischemic heart disease? Or are they having other things? So that when you see a cardiology patient, you can say, oh, okay, no, this is a valvular problem. It's a cardiology, but it's a valvular problem, this one. By knowing that it's a valvular problem, you have already covered half of the work. Then pericardium, myocardium, like cardiomyopathies. Here it can be bacterial, like TB, pericarditis, or viral pericarditis. Here, is it unstable, stable angina? Is it unstable? Is it non-stable? Things like that. At least you can fit your patient. So when you see a cardiology patient, know where to fit your patient. That's what I'm trying to say. Not only cardiology, everywhere, know where to fit your patient. It's like a PV bleeding patient. A PV bleeding patient, you must know where to fit your patient. Are they APH? Are they miscarriage? Are they Are they just A, U, B, and all of that? Which is, yeah, that's what I'm trying to say. So let's do now congenital heart disease. So congenital heart disease can be cyanotic or acyanotic. We are going to talk about the risk factors later on. One of the risk factors why kiddies are born with this congenital heart disease. So if it's acyanotic, two things can be there. They can have a normal pulmonary blood flow, or they can have an increased pulmonary blood flow. If it's increased pulmonary blood flow, it means that there's a lot of blood that goes to the lungs. So it means whatever condition that they have, whatever heart lesion they have, it makes it causes a lot of blood to go to the lungs, sort of like flooding of the lungs, if I can put it that way. So the conditions that do that are your left to right shunt. Left to right shunt. So if this is our left side of the heart, this is our right side. So in left to right shunt, you've got a shunting of blood from the left to the right. So you've got an abnormal movement of blood from the left side of the heart to the right side of the heart. Blood that is oxygenated shouldn't mix with blood that is deoxygenated. But these lesions, they make that to happen. They make that to happen because you've got movement of blood that is oxygenated to mix with the blood that is deoxygenated on the right side of the heart. So for blood to move from the left to the right side, it means that there must be some kind of communication that is there. So it means there must be a defect that is there. So what are those defects? To remember them easily, start from top to bottom. It's AVSD, what is this now? ASD, VSD, AVSD, PDA. So those are the four known left to right shunt lesions. With an ASD, as we all know that the defect is in the septal wall of the atrium. So it's here. With a VSD, it's here in the septal wall of the ventricles. With an AVSD, it's somewhere in the middle, but it makes blood in the AV, in both atria, in the blood in the left atria to be able to escape to the right side, and also blood in the left ventricle to escape to the right ventricle. It's an AVSD. With the PDA, it's different because the problem there is it's not really in the heart, but it's in the aorta. So you've got an aorta that comes like that, and then you've got your artery, your pulmonary artery there. So there's a communication here between the arc of the aorta and the pulmonary artery. So the blood that is supposed to come out like that, some comes back and go back to the lungs, come back to the heart again. So so the most important lesion, they say that this is the most common lesion, the VSD. So it's worth spending time on it. how it presents clinically, how to examine it. So I would urge you to do that and know the mama that comes with the member that comes with the VSD. This one is special because it's common in Downs trisomy 21. Actually, this is what I got for my exams. I got a kid with Downs, so I had to pick up that child has got a Downs first of all and know what heart defect comes with the Downs, which is AVSD. And also they like to ask about the issue of NSAIDs here. So you need to know that a PDA on a premature baby can close with NSAIDs like indomethacin, Brufen, things like that. But a PDA on a full-term baby will most likely require surgery. So yeah, that's basically that. So how will these babies present? So the presentation, many of these they are seen later in life, especially around 6 weeks when the kiddies come for their immunization. So it means that when they come for their immunizations at 6 weeks, they need to be examined. But if it's early, like between 1 day and a week, it's hard to pick it up. But there's an article that I was reading that they say in many of the USA PED centers, they put these kiddies immediately after birth on a SETS monitor. They monitor their SETS, and normally their SETS, when they've got so this kind of practice is able to pick up a lot of heart defects, not all of them but a lot of them. So their SETS would be around 40, 50, 60, 70 and things like that. So they recommend that this is what is done in other countries as well, because you can pick it up. And also when they've got low SETS, no matter how much oxygen you give them, they'll just not respond, and they will not pick up. So their SETS will not improve. So